Otroligt välkomna, ni som aldrig har varit med tidigare, särskilt välkommen, jag vet en i alla fall. Forum är ju ett sätt att försöka adressera policyfrågeställningar som inte är intressebaserade egentligen, utan där vi försöker diskutera någonting som alla håller med om att det här är viktigt. Jag brukar tänka, vad är det som håller Heidi Stensmyren vaken om nätterna, landstingsdirektörerna i de olika landstingen och så vidare. Liksom, vad bekymrar oss? Kanske Karin Rågsjö också bekymrad på natten. Det är ju där vi ska vara och fundera tillsammans. Dagens ämne är väl verkligen en rysare på ett sätt, men också naturligtvis en möjlighet. Välkommen till detta. Vi har 2 jättefina föreläsare. Det kommer att gå till som på vanligt sätt. Vi släpper fram dem först. Ni kommer att kunna ställa frågor. Vi kommer att ta en liten break för att ta in en tolk strax efter 2. Och vi kommer att dricka kaffe förstås. Och vi kommer att kunna diskutera tillsammans också. Så hjärtligt välkommen till detta. Är det Richard som är next? Jag glömmer alltid bort att jag måste prata lite engelska med honom.
Thank you, Torben. Very glad that we are here today to talk about an issue that is always part of the agenda in healthcare systems, and not just in Sweden, but all across Europe and beyond, but that often doesn't receive the same degree of attention that it deserves. And that's something that with the current discussion today, we will focus on in terms of the Swedish system, which is the question about how one develops, nurtures, and encourages the process of workforce development, attracting the professionals that one wants in the system, and keeping them in the system. There's always the implication that as systems change, that the staffing structure can be somewhat similar. That's not something that necessarily holds true. There also is a kind of unstated concern in a number of countries in Europe, perhaps also in Sweden. I haven't had discussions about it exactly, but that as health systems become more diverse in the providers that deliver services in the system, as you have different types of private sector providers becoming more a part of the delivery structure, also ideally more not-for-profit kinds of organizations, that's also going to alter the balance in terms of professionals and the distribution of health professionals. And then of course there's the broader issue, which is the role of professionals in moving across different European national boundaries. And that has had some impact, from my understanding, in Sweden, but that's an issue that also comes into play. It's actually a fairly complex area in terms of the broader policy planning and implementation process. So with that as a kind of broader context, we're very glad today that we have a major international figure on these issues, on the whole set of questions around health professionals, health professional mobility, future roles for health professionals, and how the process has evolved and perhaps something about where it might be heading. Jim Buchan is a professor at Queen Margaret University in Edinburgh in Scotland. He's also an adjunct professor at the University of Technology in Sydney, Australia. He's worked with these issues for 25 years. In fact, he was telling me at lunch that when he finished his PhD, his first job was working for the UK Nurses Union. So he has broad experience as over a long period of time. I think you also were a human resources director at one point for the Scottish National Executive. So he's seen the issue both as an academic and as a practitioner. He's, in that sense, seen it both from outside as an analyst and from inside as somebody who is a responsible executive. So he brings a broad perspective. He also was the lead editor on a volume, on a book on professional mobility across, health professional mobility across Europe for the European Observatory, a study that's been very well received. So we are extremely happy to have you here to lead us into the process of thinking about this. So,
thank you.
Jim.
Yes, it's correct to say that I have in the past worked for trade union and also on management side nationally. Realised both of those was far too challenging, so I became academic, which is you can tell other people what they should do and not have to try and do it. Much easier life. I'm very pleased to be here and to be able to kickstart a conversation this afternoon. I understand from discussions that this is under Chatham House rules, so we can all speak freely, think differently perhaps also. And what I will try and do in the next half hour is just give you some of my own experience-based ideas, not necessarily always evidence-based, because evidence in this area is somewhat limited. But my presentation, I think I was reflecting on this, my key message, I think, is that looking at changing roles is going to be increasingly important as we look at healthcare systems where the challenges for delivery are changing quite markedly, particularly in Northern Europe in terms of the demographic profile, but also against a backdrop where the costs and the containment of costs is a policy priority in most systems. And we are looking at a system that is labour intensive. In most health systems, 70% of ongoing costs are labour costs. So any system that's looking to become more cost effective must be looking at the labour inputs. But I'd also like to be very clear from the beginning that I'm not advocating that adding new roles to the workforce is always a good idea, because there is always a risk that we end up with a workforce that is very compartmentalized of specialists. And in most systems I know, my view is the trend has to be towards having more generalists who can provide care in the community, who can manage chronic disease, who are able to work with others in teams, rather than narrow specialists. And because of that, I thought that my first question really for the audience, and what I want to do is get us thinking about some of these issues, and I'm aware that I'm competing with a very good view, so I need to keep the audience engaged, and one way of doing that is bribery. So I'm going to begin with just a short quiz, and this is a quote about the risks of over-specialization. So you end up in a system where you have doctors who specialize, you get toe surgeons, or you get people who only operate in certain areas, are only responsible for part of the body. And I'll give a small gift to anyone who can guess the country and the approximate year. I'm also aware that because this is going out on YouTube afterwards, this is the last time probably I can offer the gift. Anyone got any guesses on what the country might be? It could be anywhere, is my view, more or less. So, it so happens it's Egypt. But the more interesting part of the challenge is, when do you think this was written?
Very long time ago.
Yeah. 450 BC. So the issue of the risk of over-specialization is not in itself new, but it's something I think that we always need to keep at the back of our mind when we're looking at how the workforce comes together, what skills are required, what roles exist, do new roles need to be created. And generally my view is that when we're looking at roles, there's much better opportunities around developing current roles than creating completely new ones. There are examples of completely new roles being introduced. One would be the physician's assistant, which is well developed in the United States, but is now being introduced in some other countries. But more often, I think we should be focusing on how can we maximize the contribution of the workforce currently through looking at adding to the skills or changing the skill mix itself. Anyway, that's just a backdrop to make us aware that some lessons have been around in the long term but not always listened to. Just in terms of terminology, and I'm aware that speaking to an audience where English isn't the first language, that there is a definitional problem around roles and skill mix, which is they are not well defined, even in English. You can hear them being presented and used in meetings, and there is often a lack of clarity about what is meant. So in terms of my own presentation today, just three to keep at the back of mind. New role is introducing a new job type, but it could be retraining current staff or developing new staff. Expanded scope is where you look at the skills or protocols of a current practitioner and look at stretching those or expanding them. This scope of practice is a phrase that is now quite well used in Anglophone countries. If you're interested in looking in detail at it, the country that is doing the most interesting work is Canada. There have been some recent publications, I have references that I can leave, where they're doing a lot of very effective work around scopes of practice of different professions and how they can more effectively align. And skill mix, the third phrase, that's looking at the different job types or professions in the workforce. Sometimes it's used in relation to what the ideal would be. Sometimes it's more focusing on what the current reality is. And a word that's used in that context quite often also is task shifting, which is essentially a more mechanistic idea around taking some tasks that are currently the responsibility of one profession and shifting them to another. So that's definitional backdrop. I also want to really put on the table that some of the issues and concepts are not necessarily universal. There was a French language review of skill mix published, I think, about 8 years ago. And it found virtually no discussion, research, writings on skill mix in French. And one of the conclusions was that skill mix was an Anglo-Saxon concept, that skill mix arose from a view of work and employment and society which did not mesh with the French perspective on life. And essentially when they said Anglo-Saxon, they are talking about countries where labour markets are freer, where there's more of understanding that jobs are not for life, that people move between jobs, move between sectors. There was also, I had contact with researchers in Chile also looking at skill mix, and they regarded it as a new idea, a new concept. And I worked in the health system in Chile a bit, and if you translate from the Spanish, in the health service in Chile, the person owns the job. That person could leave for 10 or 20 years and come back, and the job will still be there for them. So if you have that as a starting point, and you're a manager in that system, you have a very different range of opportunities in terms of what skill mix means. Now, you don't have the same flexibility as many countries in Northern Europe or North America. Also, just want to throw on the table, what do we mean by workforce? And my view is that we need to be thinking right down that continuum when we talk about skill mix. We're particularly in terms of care in the community, primary care, we need to recognise that often it will be educated, informed patients that will be providing some of their own care. And the formal workforce, the employed workforce, the professionals, might be more involved in managing, working with the patient. So the distinction between the formal workforce, those who are employed, the informal workforce, next door neighbours, relatives, carers, and the patient itself, I think need to be broken down to a degree when we're thinking about what skill means. Where are the drivers coming? The impetus for looking at expanded scope, new roles, skill mix. There are a range, and they're, I think, to a greater or lesser degree, the same in most countries. The drive for cost efficiency. In some cases, there is shortage of one type of professional or shortage of skills that need to be replaced or enhanced. In some cases, it's a drive to achieve quality improvement. It can be because we have new or changing patient needs, and I mentioned a recognition that much more will need to be done in terms of managing chronic care conditions. That leads to the need to look at skills, that leads to look at what roles need to be in the health system. When we see new technology that comes into the health sector, at the very least that requires some training to workers so they can manage effectively the new technology. But it might be more than that. It might create the need for a completely new type of role or a new clinical intervention. So there is an impetus there. We also have the kind of top-down, big-picture health sector reform, which sometimes creates the drive or the opportunity to look at changing numbers, changing mix in the health workforce. And then we have regulatory or legislative changes. A good example would be countries which have introduced legal authority for health professionals to prescribe drugs who aren't doctors. So that's happening in many Northern European countries. We're seeing nurses, allied health practitioners being able to prescribe drugs. That means their role is new, is different, is enhanced, and that has knock-on effects in terms of mix. The other main change driver is around reimbursement, and if the type of reimbursement changes, that can be a driver for change. An example I would give is the country I live in at the moment, Australia, still mainly has a fee-for-service based reimbursement model for doctors. And in that context, doctors are reluctant to have task shifting, to allow someone else to do some tasks, because when the task goes, the money goes. If you are alternatively in a salaried system, the doctor is usually quite happy for the task to be done by someone else because it's not impacting on their income. So depending on the reimbursement model, that can have a big impact on what skill mix might exist and the scope for change or the need for change. And when we translate some of those into more specific management and policy challenges, if a system or an organization is looking to develop new roles, change skill mix, what are the incentives in financing to enable that to happen? What are the human resource implications of having new roles? I've seen examples where new roles have been developed, but the system has not been prepared to accommodate the new role. So you get these bright, enthusiastic new people coming out of training, coming into the workforce, and the rest of the workforce and the system is kind of saying, well, who are these people for? And what often happens is those in the new role default back to being in the old role because that's the only way they can continue to operate. How do we foster team working if there is a change in how the team looks? There's a new person in the team. How does the rest of the team work effectively? And how do we look at issues around patient safety and quality, which are often on the table as an issue that needs to be addressed when we're looking at skill mix change, because often skill mix change is about what might be regarded as a downward shift in terms of who's delivering care. So it might be a doctor is handing over work to a nurse, or a nurse is handing over work to a care assistant. In that environment, are we confident that patient safety is not going to be compromised? It also immediately knocks into the education and regulation sector also. Are we going to need new curriculum? And anyone who works or has ever worked in a new university and has tried to develop a new curriculum knows, well, I can't comment on the Swedish system, but any other country I've been in, it's not easy. It's not something that's done quickly. It takes time. How are we going to give clinical experience to the new role? How are they going to be able to practice in an environment which isn't perhaps yet fully prepared for them? Who is going to supervise them? And there are then issues around if we are looking at a new role, is it just about a new job title? Or is it really looking at an advancement which is a broader, bigger role? Is it a new profession? There are examples of new roles being introduced, and inevitably over time they become more professionalized. They aspire to becoming a profession on their own. And one example would be physician's assistants, which 40 years ago were diploma educated in the United States and very clearly worked initially in primary care. Now physician's assistants in the United States are prepared to master's level. Many of them work in hospitals. You can see that over time new roles will change also. They may not be new anymore, but they do not stay fixed in time. How will that impact on other current roles? So when it comes to translating that into policy discourse, policy decisions at national level, I use this slide quite often, and depending on the topic, I change which ones are highlighted in red, because my experience, I've worked in about 50 countries, that if you ever have time with a health minister, she or he knows you know something about health workforce. There are a bundle of issues which translate into 4 or 5 questions which they are all thinking about. These are the issues that keep health ministers awake at night. How are we going to have the right numbers of staff? How do we plan? How do we educate? Number 1. How can we recruit and retain those workers? Number 2. What incentives do we need to have in place to motivate them to be effective, to continue to be effective? What's the best skill mix? I'm almost always asked, what's the best skill mix? What's the best ratio, doctor to nurse? I'll come to that later on. There's no answer to that, no simple answer. How do we improve productivity? How do we enable our workers to be more productive? Those 4 or 5 questions are almost always there. And if we're looking, as we are today, at new roles particularly, I think we have to touch on all those, but particularly the ones highlighted in red, are where a lot of the policy focus has to be. I'm going to touch on the evidence base, which, as I said at the introduction, is far from complete. and far from comprehensive. It's mainly been research looking at doctor-nurse substitution or nurse-care assistant substitution. It's mainly been in the acute sector. There's not so much in primary care. It's mainly in high-income countries, and most of it has been published in North America, to a lesser extent in Europe, and a few papers in Australia and New Zealand. Most of the research reports on pilot studies or one-off interventions, and the review focus is often quite short. So it's the narrative is often, we developed this new role, we implemented, we tested it, and it might be a 2-year process of review. And my own view is that that is far too short to really get a real sense on impact. There are a few systematic reviews, but not many. So we have an evidence base that is incomplete, is imbalanced towards acute sector, imbalanced towards Anglo-Saxon health systems. The point I made earlier on about those are usually systems where skill mix is a realistic option, whereas in many countries it still appears to be less clear that it is. A few key messages from the evidence base. One is, it's not a surprise, but generally speaking, the more a country spends on health, the higher are its staffing levels. Because we have a labour-intensive sector, there is a fairly strong link. There are some countries that are outliers. Cuba has a very big health workforce, doesn't spend much, but it's because it is a health workforce that's motivated to work when not very well paid. Well, that's what I'm told. Other countries might have systems like the United States, which more of the cost is tied up in administration, so less of it goes into staffing numbers. But generally speaking, more you spend on health, the bigger your health workforce. There is limited but growing evidence on the linkages between what your staff mix or numbers look like and what healthcare outputs might be. It's far from persuasive, but it's growing. And skill mix, staff mix vary notably between countries, but also often between systems and organizations, even within the same country. So the United Kingdom, where I'm from, the National Audit Office there has done reviews of nurse staffing levels at hospital level across the country. And there are unexplainable variations in staffing levels. Some hospitals have relatively high levels, some have relatively low. The only explanation is that it's always been like that in that hospital. There's no rational, logical explanation, it's historical. And you get a little bit more of a budget every year and you move things a little, but you never start with a blank sheet of paper to decide what your workforce looks like. You build on what you have. And there's no single optimal mix. Just to illustrate that, it's not showing up too well, but these are just random countries beginning with A. The red column is nurses per 1,000 population, the blue column is physicians per 1,000 population. And Sweden would be in somewhere towards the right here. Austria. Most high-income OECD countries will have a graph not dissimilar to that. They will have perhaps 3 or 4 nurses per doctor, and they will have ratios that are around about that figure. But if you look at Argentina, for example, Argentina is very representative of Latin America. Latin American countries will have 2 or 3 times as many doctors as they have nurses. So if you talk about skill mix, the starting point for skill mix can be quite different. And then if you look at Angola, if you look at sub-Saharan Africa, virtually no doctors and maybe a ratio of 1 doctor to 10 nurses, but not enough of either. So the real issue for Angola is not should we change the skill mix, it's we need to get the columns higher. So an obvious point, but one that has to be kept in mind when you're looking at international evidence, particularly that different countries have got different skill mixes and different cultural and societal norms in terms of what scope there is for flexibility in labour markets and employment. This is probably the best known bit of evidence on skill mix. It's a Cochrane review, so it's the gold standard, and it looked at the scope for substitution of nurses to take over work of doctors in primary care. I won't read through it in detail, but essentially the message from this was that nurses can produce as high quality care, that there doesn't appear to be any compromise on quality, and there may be cost savings. So that's the evidence on that particular point. Other examples which are narrower and cruder, but are the sorts of evidence that politicians and policymakers quite often can keep in their head. So an example from the United States, you can educate somewhere between 3 and 12 nurse practitioners for the cost of one physician. The second one is the UK. You can train roughly 8 nurses for the price of training one consultant. So that's crude, but it gives some sense of scale, some sense perhaps of opportunity. I quite often use this slide also because I like it so much. This is a book written by the science correspondent of the Times newspaper in England. And what he did was look at how evidence is ignored or abused by government and policymakers. And he came up with this list of different ways of abusing evidence. And I'll just look at a couple of them, but I'm sure that you are familiar with them. I know it's a very fair and equitable and democratic society in Sweden, but I'm sure some of these are ones that you recognize. Evidence shopping. So a politician will look at all the evidence that's available and take the 2 out of 10 bits that support the argument they want to put forward. Imaginary evidence, referring to something that is there but isn't really there to justify an argument. Secret evidence. We have the evidence but we can't show you, but please believe us, it's telling us we should go in this direction. So evidence on its own is not enough. The evidence is not complete. We need to build on it, but we cannot rely on evidence to make the change for us. And we need to recognize that we're working in a political and policy domain where there are interchangeable priorities, there are stakeholders who have different views and perspectives. I quite often use this slide also. This is a published quote from the then Prime Minister of Australia. It came out 6 months ago. And I found it quite surprising that a politician might think this, but to say it so that it was published, I found quite remarkable, in the sense that essentially what he was saying was that I do what the doctors tell me. And he's no longer Prime Minister. I don't know if the two facts are connected or not, but the reason I put this up is that if you look at the high-income Anglophone countries, Canada, US, UK, New Zealand, Australia, Australia is the only one of those countries where there has not been much progress in introducing nurse practitioners as a new role. Australia, as I said earlier, has fee-for-service. So the Australian Medical Association has been very opposed to any moves towards having nurse practitioners. And if you have a political statement like that, you can see how it's very difficult to get that change. Even if the evidence is there that it makes sense to do it, if you have a political apparatus that takes that view of the influence of one profession, not all professions, but one profession in health, the other professions have got a very difficult selling job to make things different. I think it's unusual in it's being so straightforwardly presented, but I think it is an issue in most countries at some point in time, that one profession or one stakeholder will have undue influence, influence beyond what they should have in terms of allowing things to change for the better. A few slides to conclude. So what needs to be in place to allow expanded scope or new roles to happen, or what might be in place to prevent that happening? Firstly, there's the issues around the workforce, the professions, the trade unions. Are they in supportive of change? Are they concerned about the direction of change? They can stop it happening quite often if they're not persuaded it makes sense. So they have to be part of the process. How is care organised and structured? Is it structured in a way that is going to enable new roles to make a good contribution? Funding mechanisms. Is there a need to look at changing funding mechanisms? I mean, many countries, the United States being one, has moved from fee-for-service in terms of paying primary care physicians to a more blended approach, recognising that if you only have fee-for-service, it's going to create a very rigid system without much scope for flexibility. What incentives, financial or non-financial, can be put in place to encourage direction of change? Is there a need to look at changing legislation? The most obvious example, as I said earlier, is if you have identified that health professionals other than doctors being able to prescribe is a good idea, there will be a need for legislative change. And what does that all mean in terms of education and training? So you look at this list and you immediately recognise that it's not just health, it's education, it's regulation, it's legislation, funding as well, all need to be part of the consideration if it's a big change that's being considered. Also, I really want to emphasise that if you are looking at introducing a new role, it doesn't necessarily happen very quickly. This is a summary of the stages in terms of the introduction of nurse practitioners in the United States, and essentially we've had 50 years or more, and these authors recognised that there was a process of persuasion, legitimization, maturity that were required to reach a point where there were sufficient nurse practitioners to have an impact. And part of that process is ensuring that the public understands what the new role is and can contribute. I had a personal experience of that when I lived in the UK maybe 10 years ago. The general practitioner, who was my one, introduced a nurse practitioner. And I went to the practice one day, and I was provided with a short handout saying, we now have a nurse practitioner. This is what she can do. If you're comfortable and wish to, you can see her. And I was quite comfortable with that, partly because I understood nurse practitioners, partly because you could see her straight away. You had to wait to see the general practitioner because he had other patients to see. So this idea of communicating change and the benefits of change is part of what needs to be considered when a new role is being introduced. So it's engaging with the population, with the consumer. Right, I'm just really concluding now. So what would I regard as the key stages? Now, these are presented in a linear fashion, but usually life is a bit more complicated. So it's not tick 1, move to 2. It's usually a bit more to and fro. But key stakeholders need to understand and agree what the new role is about, what the principles are, what the timeline is. There needs to be very clear definition about what these new roles might be, and also what the implications for education and training are. Any issues around regulation, accreditation need to be determined, and any issues around employment and human resources. If you have a fixed career structure in your hospital and a fixed pay structure, where will the new role fit in? And then when you introduce it, there has to be some sort of monitoring, evaluation, agreed indicators of improvement, of change. And I think, as I argued earlier, these need to be across a reasonable period of time. These are just 3 slides to finish. My own kind of views and reflections, I guess. Where possible, harness local innovation, build on it, and use networks that exist. Top-down implementation of a new role will not work. You do need policy endorsement, you do need a regulatory frame if you want something to change nationally. But if you try and create it nationally without the ground being ready, without the workforce being ready, without the population understanding the change, it won't happen. Local knowledge and networking, critical to success. I think if you can do some rapid evaluation and get early lessons out, that can keep the impetus going. But that in itself, as I said, is not going to be enough. Communications, vital to any developing of a shared purpose and also to ensuring community buy-in. Recognizing that teams are not fixed in time forever. There are teams that exist, but people come into them, come out of them. Healthcare, particularly in hospitals, is very rapid throughput now. And if we really are talking about interdisciplinary, it's not just that you have one doctor, one nurse, one social worker in the room. It's much more than that. It's got to be a sense of mutual respect, active engagement, development of shared purpose. I've been in a couple of countries where doctors are happy to be part of the team as long as they lead the team. But we need to get beyond that in terms of a discourse. Final slide. Don't think about new roles till you've worked out what your problem is. There might be easier solutions than introducing a new role. But if you have decided that's what you need to be doing, look at the evidence base, pick up on the key messages, look at what other people have done, and make the connections in terms of teams and organizational performance. But when it comes to actually the process of implementation, there are technical aspects of it, but those are relatively straightforward. I think most of the effort and most of the energy is around change management, and that's community engagement, using the media effectively, that's old media or social media, communications, being clear about terminology, involving staff, involving other stakeholders, including consumers and patients. So I suppose my final message there is that I think most health systems need to review and consider where roles can be more effective, but I think that will often be advancing current roles rather than creating completely new roles. But even where that is the case, you need to think through these what next points. Thank you for your attention. There are, and I can arrange for these to be made available, I've got a couple of slides of references, mainly of new work in this area that might be of interest, but I'll conclude now. Thank you.
Thank you. Thank you very much, Jim. Very helpful, very comprehensive.